Erin, can you just unmute? It's gone onto mute.
Nice. We're starting off on a good foot today. Well, welcome everyone. We are in our 4th week of our training, and this training is an introduction to palliative care, specifically focused on providing care in humanitarian settings. So you may find that you are working in a refugee camp, or you're working in a community with refugees, or you're interested in working in these settings. This is an 11-week course, and we're really glad you're here. My name is Erin. I'm a palliative care nurse working in Kenya. I'm from Toronto, Canada, and we have several other of our faculty members on the call today. So anyone that you see on the call that has a hashtag in front of their name, they're one of our faculty members. We have Ann Kellerman, Dr. Anna Vork, Esther Beatty, Dr. Kathryn Richardson. We have Ali Hamid, clinical officer in Kenya. And we are hoping that Dr. Esther Nafula will join us shortly. She's just on another call, but she's joining in. Today, the topic is going to be opioids in pain management. So I want you to think back to your medical training, your nursing training. If we have any pharmacists on the call, think back to your training and think back to the session when you learned about opioids. And we are hopefully going to reaffirm the things that you learned in class. But for some of you, it may be a while back, or you have forgotten about it and you don't normally work with opioids. So today might be a session that you, you might be learning something new. You might be learning some new techniques, and we're really hoping you can begin to implement some of the things you've learned through the program in your day-to-day work. So let me share my screen. And we'll get started. Dr. Nafula should be joining shortly. I guess if one of the other faculty members see that she's joined, just let me know. Let me just change it to full screen. Okay, so today I will be sharing details about opioid management. And what we really want to focus on today is just to understand a bit more about what options there are for people that are in pain, and what can we access locally in our East African context, especially in humanitarian settings. Kathryn, I may just ask you to monitor the chat. Oh, there's Dr. Nafula. Perfect. I didn't even get to do one slide. Okay, so I'll let Dr. Nafula just get organized and set up, but our objectives for today will be that you will be able to explain the basic principles of pain assessment. So first we need to assess our patients and their pain, and then we will be talking about the basic principles of pain management. So once you assess a patient in a clinic or in a hospital setting or even in a home-based visit, what are your options? How do you manage their symptoms of pain? And then to become more familiar with the analgesic options of opioids. Welcome, Dr. Nafula. When you're ready, you can definitely take over. I can just continue to share my screen. So today, I want you to remember the importance of managing pain, especially when we think about palliative care and holistic supportive care, is that there are serious consequences for untreated pain in our patients. As you can see here is a picture from Kenya of a patient that is sitting on the ground beside her bed, and she looks quite uncomfortable. You see that she's rubbing her eye. She's kind of sitting in a position that doesn't look so comfortable. In the right bottom corner, you can see, though, there is somebody else there with her, and it looks like I can identify that there's actually a bottle of liquid morphine there. And I want you to think of this patient in this setting as we think about and we begin to understand more, why do we talk about assessing and management of pain? Because actually, when we leave pain untreated, anxiety and depression can come. Patients have increased suffering, and we know that their quality of life is decreased. This is something really important that we need to begin to understand, and we need to continue to challenge our colleagues as well to understand that pain assessment and management is really important. So as we think about pain assessment, there are several things we need to remember. So it is really important that we take a good pain history. We ask patients about when they started having pain, if there is anything in particular that makes it worse in their daily routine. We need to understand if they've had any injuries or accidents. If they have chronic pain, they can explain that a bit more. It is also really important that we understand their diagnostic history. Do they have a diagnosis? Are we still trying to identify what their primary diagnosis is? This can all be done in a very thorough history as we do a pain assessment. And going forward, I can share, after the call today, I can share some templates. I'm sure even Kathryn, you may have access to some templates that we could share with those that are maybe working in settings where they don't have full palliative care services at the moment, or any of the faculty members, if you have access to examples of what could be done, so we don't forget any questions during that assessment. That might be nice for us to share.
I'm ready now, Erin. I can continue. Sorry for joining a bit late.
No, that's fine. That's fine. Karibu. I just talked about history. You're welcome to say it again, but I was going to go on to examining.
I can start. Yeah, I can start from that slide on pain assessment.
Perfect.
So, yes, thank you. As Erin has said, when we are assessing pain, it's good for us to try and establish the diagnosis or the underlying factors causing the pain. So we start with good history taking, examination, then investigations. We can go to the next slide. So when taking a history, first we want to know what, where, when, timing or duration, treatment, changing and cause of the pain. So when we are asking what, the patient will tell us that maybe they have pain. Then where, we want to know which part of the body has pain. When does the pain happen? When did it start? Does this pain have a pattern? Is it worse in the morning, worse during the day? What has been the response to treatment? And here treatment, we look for treatment for the underlying condition as well as their experience with analgesia. Have they had side effects with the pain medications? How are they taking the medications? Was the medication prescribed or was it gotten over the counter? Then, of course, the aim is just to establish what is causing the pain. So some patients may already have a diagnosis, others may not. Next slide. So we have some scales that are used to assess the severity of pain. And there are scales that have been validated for use in adults and children. So for adults who are literate, we use the numerical rating scale, which is a scale that has a 0 to 10, and we ask the patient to choose the number that corresponds with their pain. For children above 3 years, we use a Wong-Baker or the faces scale, where again we show the child these faces and we ask them to choose a face that corresponds to their pain. So 0 is a smiling face and 10 is a crying face. So again, 0 is no pain and 10 is the worst possible pain. Next. Sometimes we can use our hands, which is a very simple scale to use. That do you have small pain, medium pain, or big pain? And this sometimes works for our patients who are illiterate or who may not really understand how to use the other scales. Next. The FLAC scale is a behavioral scale, and we use it a lot for children who are nonverbal. So really, we look at the activity. So we look at their face, their legs, their activity, their crying and consolability, and we look at the expressions. There's If they have a facial expression or a smile, or they are calm, are they relaxed? Are they throwing their hands around? Are they crying? And if a child is crying, can they be consoled by their guardian or not? So again, the minimum score is 0 and the maximum score is 10. So basically, between 0 is no pain, between 1 to 3 is mild, 4 to 6 is moderate, and 7 to 8 is severe. Next. We manage pain in palliative care by 3 principles, and the first is by the clock. So by the clock means that medication should be given in a timely fashion. So if it is 8 hourly, then it has to be given every 8 hours. If it is 12 hourly, it has to be every 12 hours. By the mouth, we prefer to use the oral route because most patients have chronic pain and they have to be on analgesics for a long time. And the ladder here is the WHO ladder, which has 3 steps for adults and 2 steps for children. Next slide. Yeah. So for adults, the WHO ladder for managing especially cancer pain has 3 steps, where step 1 is for mild pain, and we use non-opioids, which are NSAIDs and paracetamol. Examples of NSAIDs in our setup include brufen, diclofenac, aceclofenac. Then step 2, we use weak opioids like tramadol or dihydrocodeine. And step 3, we use strong opioids like morphine. So adjuvants here are medications whose primary role is not to manage pain, but they act on pain pathways. For example, anticonvulsants and antidepressants. So we can use those ones at any step of the ladder. Next. So opioids are very important for medical use. They are in the list of essential medicines from 1977 for both adults and children. And when you look at the essential list for palliative care medicines that was developed by the International Association for Hospice and Palliative Care, opioids are also there. So it is very necessary for us because a lot of patients will come with severe pain. So we are going to spend a few minutes just talking about some considerations and some facts about opioids and specific morphine that we use a lot for pain management. Next. So yeah, opioids are natural products. They are derived from opium poppy. And as I've mentioned with the WHO ladder, they're classified as weak and strong opioids. So weak opioids, we have codeine, dihydrocodeine, and tramadol. Then the strong ones, we have morphine, methadone, oxycodone, and fentanyl. Next. So opioids, and here pharmacokinetics, I'm going to talk about morphine because morphine is the prototype. So morphine, when taken orally, it is absorbed very quickly. Actually, the syrup is absorbed within 10 to 15 minutes. And morphine is well distributed to body tissues. It crosses the placental barrier. It goes to the brain. It's metabolized in the liver and excreted in the kidneys. So we do have oral morphine solution in tablets that we use in our setup. So the oral solution or immediate release tablets, we give them every 4 hours because they have a half-life of just 2 hours. Then for the sustained release, the half-life is about 12 hours. So we give the tablet every 12 hours. Next. So opioid receptors are found in the central nervous system. So in the ascending or descending pathway, so that is in the spinal cord and the brain. So opioids work by inhibiting activity, partly through direct activation of the receptors and through release of endogenous opioids that exist within our bodies. So this is why some of the side effects are associated to the brain because the opioid receptors are found in the midbrain. Next. So the common side effects include sedation, respiratory depression, nausea, vomiting, constipation, and euphoria. So when we are prescribing morphine, we usually give a laxative to prevent constipation. Now, when we use it for a long time or chronic use of opioids will lead to tolerance, dependence, and hyperalgesia. So tolerance is physiological, it's a natural physiological phenomenon where someone needs a higher dose of opioids to be able to get an analgesic effect, and it is normal. Dependence and addiction are mental health problems, although with the use of morphine for palliative care or for cancer pain, the rates of addiction are very minimal. So we should not fear prescribing opioids or morphine because of addiction, but we should just know how to use them correctly. Next slide. So we've talked about the dosages. For the immediate release tablet, which is the common one, it is readily available. It is actually a bit cheaper than the tablet, so it is more available for use in palliative care. The way to calculate the dose is 1 milligram per kg per dose per day. So 1 milligram per kg per day for an adult of 60 kgs comes to 60 milligrams, which then we give in divided doses. So the patient will get a double dose at night to avoid waking up every 4 hours, and then the remaining 5 doses they get every 5 hours. Where sustained release tablets are available, the dose is still 1 milligram per kg per day, but we divide it into 2 because the half-life is longer for the sustained release tabs. Next. So when we're dealing with these groups of patients, we have to adjust the dose. When we have patients who are elderly, and that's more than 65, we want to give them 5 milligrams of morphine instead of 10. Patients who have renal or hepatic impairment, we also want to adjust the dose depending on the function. For pregnant or lactating women, we do not use opioids unless it's absolutely necessary, because opioids are going to cross the placental barrier. So for unborn children, they might be born with an neonatal abstinence syndrome because they have been exposed to opioids. And also for the lactating mothers, the babies will be exposed to opioids. So we really have to have a multidisciplinary team discussing and agreeing on how to manage pain in the pregnant population or the lactating women. Where we need to use sedatives or anesthetics, it's also good to consult, because then sedatives and anesthetics combined with opioids will cause respiratory depression. Next. So there are many myths around morphine, and I will just go through the topmost, a few of them. So there's a myth that morphine should be held until the last days of life, that if a patient is not dying, we should not give them morphine. That is false, because morphine is a strong painkiller, and we use it for severe pain as soon as we identify the pain to be able to improve the quality of life of patients. There's another myth that morphine hastens death. So palliative care is not about hastening death or prolonging the dying process, but we give morphine to ensure that the patient has good quality of life with relief of suffering, and even should the patient die, that they're going to die without pain. That morphine causes addiction. There are patients who have pain and need morphine to manage their pain do not become addicted to morphine, and research has shown that among patients receiving palliative care, addiction to morphine is very minimal. It's actually less than 1%. Next. Yeah, I mentioned that tolerance is biological, and it's the body gets accustomed to the dose of morphine. Addiction or dependent, on the other side, is psychological. So someone has a strong desire to take a drug, not because they have pain, but because of the psychoactive properties. So they want to get euphoria, or they want to get a high from morphine or from other opioids. And addiction and dependence are problems that are managed by the psychiatry department. Next. So that is it about the pain presentation. So what we want you to remember from this presentation in terms of principles of pain management is that first you have to identify the patients in pain. Then you have to be able to assess the pain well using the appropriate tools for the age of the patient. And after assessing pain, please remember that we manage pain by the clock, by the mouth, and by the ladder. So always have your WHO ladder handy, and you should know which medications to choose for which patient, and communicate with the patient so that they understand how to take their medication by the correct hour, times 3, but the patient takes their medication 8 hourly or 12 hourly, and that way when we need to adjust analgesia, it is very simple. Thank you. I think we can take questions before we go to the case.
Yeah, for sure. Thank you, Dr. Esther. I think I'm also reminded that it can take a while to feel comfortable with prescribing opioids. And I know a lot of our healthcare providers are, constantly seeing patients and may not have the ability to do a lot of studying related to opioids. But I think it is really important that if you are going to try to implement and start treating patients with opioids that you have access to, that you do read up on how to prescribe and even just review this session today. But if there's something that you need support from Dr. Esther right now, does anyone have questions? So Esther from working in Senegal has a question to clarify, Dr. Esther. Does morphine work for every kind of pain? For example,
yes, morphine is not recommended for use of chronic non-cancer pain. So if your patient has chronic pain and cancer is not the cause of that pain, it is not recommended that they use morphine for a long time because of these issues of addiction and dependence. So for patients who have chronic pain that is not cancer pain, then we want to isolate the cause of the pain. And sometimes if it is nerve pain or neuropathic pain, we want to try and see if they can get interventional pain management, things like regional blocks, nerve blocks to manage their pain. Because now for cancer patients who are on morphine, sometimes once we treat them, the pain might go away, or if the patient has advanced cancer, then they are going to use morphine just for a short time because their prognosis is bad. But for the patients with other types of pain, then we want to consider other types of pain intervention apart from using opioids. So the book is also asking if you can use morphine for neuropathic pain. Unless the neuropathic pain is caused by cancer, you cannot use morphine for chronic neuropathic pain.
Yeah, is there anyone that's currently providing pain management for patients where they don't feel like they have good access to either morphine or tramadol or the other medications that Dr. Esther was talking about today?
Good afternoon, Erin, once again.
Hi, Ali.
Yeah, I would like to ask one question, Dr. Nafula, Esther Nafula, about the opioids, the weak opioids and the strength of this. In the session, she said it across the placenta. So is it contraindicated to give a pregnant mother also the weak opioids?
Yes, opioids do cross the placental barrier. So we do not use opioids routinely in pregnancy, but sometimes we've had patients with the pregnancy and cancer. So we do use opioids, but in that case, you have to monitor the child. Once the neonate is born, then they have to be given treatment for neonatal abstinence syndrome because the child is exposed to opioids. So that baby will be treated the same way babies who are born to mothers who are addicted to heroin will be treated. So routinely, we do not give. And when we have to give, it is good to consult with the obstetricians.
So what is the current alternative available for that pregnant mothers? They have been.
The only analgesic that is safe in pregnancy is paracetamol. That's the only safe medication, because even NSAIDs have effects on the unborn fetus. They cause the premature closure of the ductus arteriosus. So even NSAIDs come with a lot of side effects when given to pregnant women. So for pregnancy, only paracetamol has been approved for use. Any other medication that has to be used in consultation with the pain management teams and the obstetricians.
There's a good question here, Dr. Nafula. Some of our faculty members are answering some of them, but I would love for your response on can the effects or the side effects of opioids actually contribute to the deteriorating health of our patients under palliative care? This could be from a health care provider's perspective or even from the family's perspective. How do we approach that?
Yeah, so when prescribing opioids, it's good to educate the patient and the family on the side effects, but also you need to have discussed the diagnosis and prognosis. Some patients, for example, in end of life will already be drowsy, they'll be fatigued, they'll be having shortness of breath. So when we need to give them morphine, it is good for the family to first understand that the health of the patient might be deteriorating, not because of the opioids, but because of disease progression. And sometimes if the patient is very weak, we give a lower dose. We start at a lower dose until the patient develops tolerance.
And I think directly that opioids would not further deteriorate someone's health. It is used to support
Exactly,
them.
yes.
Yeah. There's a few more good questions here. What do we do if someone is allergic to morphine?
Okay, if someone is allergic to morphine, the other strong opioids that are used include oxycodone and fentanyl patches, and in some setups they use methadone for pain relief. But again, the issues with those other strong opioids is availability and the affordability. Like oxycodone is very expensive in our setup, so a lot of patients are not able to afford it. So, but then if a patient is actually truly allergic to morphine, then we cannot give it. And sometimes we have optimized the dose of dihydrocodeine. We can give up to 60 milligrams QID if the patient is not able to stand morphine.
Can you say that one again?
Dihydrocodeine, DF-118, yes, dihydrocodeine. So sometimes we optimize and give a higher dose, yes, at 60 milligrams QID, yes.
Okay, and then someone says, do opioids affect people with cancer metastases?
Do opioids affect?
Yeah, the question's not so super clear, but I guess I can answer it. With patients who have metastases, we would often suggest to use opioids because these types of
metastases to the lungs.
Okay, so can you use opioids like morphine for people with lung cancer?
Yes, actually morphine is good for patients with lung cancer because morphine is also the drug of choice for managing dyspnea. So it will work both for the pain and the dyspnea. So yes, we use it. I think morphine is only contraindicated if a patient is on, for example, anesthetics, sedatives, or when a patient is allergic to morphine. But for medical conditions, for all cancers, we are able to use it safely.
I feel like I should say an amen or something like that. I think we all agree with you on the faculty team. That's great. Okay, there's another good one here about adjuvants. I would like to ask for some reminders regarding the use of adjuvants for chronic pain. So I think that we have clinicians and healthcare providers on the call today that may not only be seeing people with cancer pain, but maybe other types of pain. And what is your suggestion?
Now, in our formulary for the country, pethidine is no longer one of our essential drugs. And the reason for that, first of all, it has a shorter half-life than morphine. So it needs to be administered more frequently. Then there have been a lot of issues with addiction over the years with pethidine. In some setups, it's called meperidine. So again, for pethidine, even when in use, would be good for acute pain because of the mechanism of action, and it lasts a shorter time. So for chronic pain, chronic cancer pain, we want to use morphine because we are able to offer pain relief, and the patient is able to take the morphine home, because now pethidine, the patient has to be within a setup where we can monitor how we are giving, because it's an injectable opioid, so the patient cannot take it home.
And other adjuvants such as NSAIDs or the
Yes.
neuropathic?
Yeah, so yes, so again, when the patient has a mixed pathophysiology of pain, sometimes they have a neuropathic component. We give morphine, we can give morphine together with an NSAID. We can give opioids and NSAIDs together, and then we can add steroids, anticonvulsants, or antidepressants that are likely to also improve the experience of the neuropathic pain.
And that would be examples such as the gabapentin or? Ali, can you access gabapentin?
Yes, gabapentin, pregabalin, carbamazepine, amitriptyline, those are the common ones we use in our setup.
Yeah. Ali, can you access those in Hagadera?
Yeah, we have tramadol, you have morphine, we have gabapentin, we have pregabalin, we have amitriptyline. Those drugs, all of them, are available.
Okay, nice. Okay, maybe one of the last questions. What's the antidote for morphine?
The antidote for opioids is called naloxone. So it comes as an injection, a vial. So when a patient has respiratory distress, that one vial is given in normal saline over 20 minutes. If they have developed pruritus or severe itchiness because of morphine, then it is given over 12 hours. So it is good to confirm that you have some naloxone available in institutions, or that you can get it or be able to access it when you need it. We rarely need it, but sometimes when you do, it is good to know where and how to get it.
Yeah. Okay, I think we've done really well. The last question I see here, but I see there's lots of new messages, is, and then we'll just respond to the rest of them through the chat. Can you prescribe morphine for heart disease or a patient who is having cardiovascular disease?
If a patient has heart disease, you see, morphine is used. For example, if a patient gets a myocardial infarction, morphine is the drug of choice for pain management, but for a short time. Then we have some patients with heart failure who might be in end of life and also may need pain management with morphine. So it can still be used, but you have to look at the context of the patient and the diagnosis.
Okay. Dr. Esther, before you fully go off the call, I'm not sure what you're up to now. There's a few questions here that we didn't get to. Do you mind responding to them into the chat? Or Dr. Kathryn's going to do the case now, or Dr. Anna?
Yes.
What's the maximum starting dose for codeine, as well as using pain management in children?
Okay, I can respond to that. Then any other questions, I'll respond in the chat.
Okay,
so the
thanks so much.
dose, yes, yeah. No
Thank
problem.
you
I think
so much.
Let me respond.
Okay. So we'll switch over now. Please do continue to put any questions in the chat. This is a really important topic that we want to focus on, and we want you to feel confident in. We know that the issue of accessibility is very serious in low resource settings. So also if you're having issues accessing morphine, we definitely want to know that. We are a group of international providers on the faculty team, and we have people working in difficult situations. So we definitely want to know when there's limited access to these kinds of medications to do palliative care well. So please don't hesitate to either put it in the chat or email me. We would love to follow up and find ways to support you where you're working. So I'll pass it over to Dr. Kathryn. She was our facilitator last week, and now she's doing our case presentation. I think you guys know her well. But welcome, Dr. Kathryn.
Thank you, Erin. So what we'll do now is we'll run over a case to just demonstrate how we use some of these pain medications we've just spoken about, in particular morphine. If you have any questions as we go along, feel free to raise your hand or put your question in the chat. So this is a case of a 35-year-old man who was an inpatient in a health facility in the region. And he presented with quite a nasty tumor. You can see a picture of the wound here. He did not have access to oncology treatment, and he presented with already very advanced stage disease. And his main issue, which I'm sure most of you will appreciate looking at the wound, was that he was having severe pain, and this was preventing him from sleeping. So taking a pain history, he shared that his pain was continuous over the large area of the face where his wound was. And he described it as 9 out of 10 in severity using the pain scales. And he found the pain was worse at night when he was lying down in bed trying to sleep. And he hadn't actually slept for many days at the time of review. And he also had worse pain at the time of dressing change, because often the dressing was being stuck onto the wound, causing increased pain when the dressing was being changed. The team had tried some morphine. He tried it just, it had been written as an as-needed medication, and it did give him some relief. And it was initially being used prior to dressing change, and it reduced his pain score from 9 out of 10 to 7 out of 10 when he'd taken the morphine. So here are some of the other symptoms he was also experiencing. So his appetite was reduced, his mood was quite low, and he was very withdrawn, spending most of the day sat on his bed and not really engaging with other people. As we mentioned, his sleep was poor, and there was a very strong odor from the wound. And one of the first pieces of information about this patient was that the smell was so strong that the team and the other patients could smell the wound even from outside of the patient's room. There was also a lot of bleeding during dressing changes, and he was having a lot of itch at the site of the wound too. So this man was married, he had 5 children. His village was far from the health facility, and his father was present with him. He was the main caregiver, and he'd been a long stay patient on the ward. So he'd been there for several weeks, and there was no plan at this time to get him home because of his difficult symptoms and because of the wound care and management that he needed. He had a strong faith. He was Christian, and this was important to him. So if you all just think now about how we might be able to manage this man's pain. So think about the WHO analgesic ladder, and we've just learned about the step 3 ladder, and have a think about which step you think this man may need to manage his pain from the history we've already shared. Which medication should we try, and at which dose? So while you think about that, I'm going to go on with the case. Feel free to write any suggestions in the chat or any questions you may have. So it was decided that actually having just the as-needed medication was not effective for this man, partly because it was only being given before dressing change, and he was not asking for pain relief, even though he was in severe pain. So it was clear that he needed to be prescribed a regular analgesia. Okay, and actually for patients, as Dr. Esther explained, it was by the clock, by the mouth, and by the ladder. So as Dr. Esther clearly explained, for continuous pain, we need continuous analgesia. Okay, PRN analgesia is okay for intermittent pain, but when you've got pain that's present all the time, you need a continuous analgesia. So this man was started with morphine, immediate release, 10 milligrams every 4 hours. So this would be equivalent to the 1 milligram per kilogram sort of dose. He was around 50 to 60 kilograms. And he was given the same dose as a PRN. So usually the dose we prescribe every 4 hours is the same dose as the PRN for immediate release morphine. And we said he could have this up to every hour if needed. And we should also give it routinely 1 hour prior to dressing change, even if he's had his regular dose. Alongside the morphine, the team prescribed regular laxatives as well. He was, I don't know if we mentioned in the symptoms, he was already constipated. And actually, the most common side effect from morphine, and almost all patients get this, is constipation, because there are opioid receptors in the gut, and actually you get some paralysis of the gut. So almost all patients need co-prescription with laxatives when you prescribe morphine, certainly regularly, even PRN. The exception is patients have diarrhea, okay? And what you'll find is morphine will probably improve their diarrhea. So with the regular morphine dose, this man's pain improved to about 6 out of 10. Okay, so it came down from 9 out of 10 to 6 out of 10. And with this, his sleep improved. So he started sleeping a little bit during the night time. And he was taking around 3 or 4 additional doses in 24 hours. So I have to think now, what would be the next step for managing this man's pain?
Dr. Kathryn, in the chat, there seems to be a bit of, people are giving a bunch of different recommendations. So I don't know if you just want to go over your recommendation.
Thanks, Erin. Yeah, super. I was just checking them now, so that's great. So yeah, I agree with all of you who said step 3 opioids. We know this man can tolerate morphine. He'd had already PRN doses. And he was going to need step 3 opioids. Now, if you don't have experience of that, it's fine. So this man has had pain for a long time. You know, if you have experience with managing this sort of pain, you're going to know he needs morphine. But if you're not so sure, you can start with step 1 and quickly move to step 2 and quickly move to step 3. Okay, so not asking you to work outside of your comfort zone. And there would be nothing, it would be absolutely fine for this man who has had this pain for many weeks to start with regular paracetamol. And if later that day it wasn't managed, to add in codeine or tramadol, and then you'll probably quite quickly find you need to move to the step 3. So that would be absolutely fine as well. And so there were some suggestions initially to give 10 milligrams PRN. Well, that would be fine for people who have pain sometimes, okay? But when you have continuous pain, you usually need a continuous analgesia, okay? And we'd already tried PRN for this man, and his pain had not really much improved significantly. So this man was going to need regular. And I can see, Florence, here you suggested morphine 5 to 10 milligrams QID as a starting dose. So again, 5 milligrams, would not be wrong as a starting dose, but QID maybe, this man had normal renal function, he had normal liver function, he was not elderly, so 4-hourly prescription is better than 4 times a day. Because otherwise you'll get peaks and troughs, right? So your pain relief will start wearing off at 4 hours. So you'll leave someone exposed for the next 2 hours till they had their QID morphine after that. So we give it 4-hourly unless there's a good reason to increase the frequency of the dosing, like liver impairment or renal impairment. Okay, and there's some good answers here. So Moza, you had the right answer there with 10 milligrams every 4 hours with PRN. That's excellent. Okay, and there's a comment here: we can give morphine every 8 hours. So we could switch to sustained release morphine. But what we usually do is we titrate and get the pain controlled on immediate release morphine. And then once pain control is, we can switch to sustained release if you have access to it. So it's much easier to titrate pain relief on immediate release, because if you give too much or too little, you can easily add in, and the half-life of that medication is shorter. So when you're moving the dose around, it's easier to do so, certainly initially, with immediate release morphine. Okay, so let's think about what is the next step for pain management. So we have now a man whose pain has improved with the 10 milligrams of morphine every 4 hours. So what's the next step? So just have a think about what you might do next. And this is what we actually did. Okay, so this is a man whose pain was responding to morphine. It had already improved some with the morphine every 4 hours, 10 milligrams. So this tells me, and the man was tolerating that. He was awake. He had no signs of having too much opioids on board. So we could very safely and easily increase the dose of morphine, which is what we did. And we increased it to 20 milligrams every 4 hours. And when we increase the regular dose, we need to also increase the PRN dose as well. Okay, so we increase the PRN dose also to 20 milligrams, as well as the dose before the dressing change as well. And actually with this, he reported his pain was controlled. And at this point, just to stop him having to take the medication every 4 hours, we changed him. We were lucky enough, let's say, to have sustained release morphine. So we changed him to 60 milligrams of sustained release morphine every 12 hours. And we got that dose by adding up the total 24-hour dose of immediate release morphine, which would be 20 milligrams times 6. That gives you 120 milligrams, and then dividing it by 2 to get the sustained release or 12-hourly dose, okay? So that's 60 milligrams. So he would have 60 milligrams of sustained release morphine every 12 hours, but we kept the PRN as immediate release. The PRN is always immediate release. We don't use sustained release for PRN. And we kept the 20 milligrams immediate release before the dressing change as well. Okay, so yeah, here we are. Okay, and actually, it was really good to see when this patient, when his pain was controlled, because what we found is that he started to engage. Okay, so while he'd been really withdrawn and quiet, when his pain was controlled, he started coming out of his room. He started sitting with other patients, and he really started to be more interactive with others. Okay, so it was really lovely to see the change in him when his pain was better controlled. And I shared with you earlier some other symptoms, and while this is really a pain case, I'll just go over a couple of the other symptoms and how we manage them as well. So he had quite a bit of itch at the wound site, and we prescribed antihistamines, and we used a sedating one because this also helped with his sleep at night. And his sleep was really much improved with the pain control, and with the addition of the antihistamine, he was sleeping well. And we watched carefully to make sure that he wasn't too sedated with that combination. So his mood was improved with pain control, and he was continuing to be supported by the mental health team. And he was also having some spiritual support from some of the faith leaders in the community as well. And here's a really good tip. So for patients that have fungating wounds, that have quite a strong or a bad smell, this is caused by anaerobic bacteria, usually anaerobic bacteria just growing on the surface of the wound, okay? And the toxins that they produce, the chemical reaction causes this really bad smell. And there's something you can do that's so simple, and it makes a huge difference to patients and their families. You can just crush some metronidazole tablets, and each time you do the dressing change, just sprinkle the crushed metronidazole tablets onto the wound, okay? And it really, in my experience, and it's supported by evidence as well, it really improves drastically the odor from the wound. And we shouldn't underestimate how much of an impact that has, positive impact that has on for patients and families. And the bleeding that was occurring during dressing change, we were using tranexamic acid, and we applied that to gauze at the bleeding site at the time of dressing change as well, and that stopped the bleeding. Okay, so I'll just quickly check the chat to see if there's any other comments in. I don't. Oh, okay, thanks, Esther. So you've got a question here about whether you can prescribe immediate release and sustained release at the same time. Okay, so that's a good question. So the regular medication should be either immediate release or sustained release. Okay, so it's one or the other. And we always prescribe, in addition to regular medication, an as needed or PRN medication as well. The PRN is always immediate release, and the regular medication is either immediate release every 4 hours or it's sustained release, which is usually given every 12 hours. You can also get 24-hour sustained release opioids, including morphine. So just check carefully if you're using sustained release, the kind of preparation you have. Most are every 12 hours. You can occasionally get 24. Also, if you have, quite often you might not have the right dose to give it over 24 hours. Okay, so you may need to give a dose that's lower or higher. And what you can do then is give it 8 hourly. So if you have, let's say you have 20 milligram sustained release tablets, and you need to give a dose of 60 milligrams in 24 hours, you can actually give 20 milligrams every 8 hours. So you're giving the same dose rather than going up or down on the dose. And I've done that in settings where we haven't had access, and it does actually work very well. So that would be a reason to use sustained release every 8 hours. So you can use the doses of medications you have. You cannot break a sustained release tablet because it will become immediate release. Okay, and the patient may become toxic and have too much opioid on board. So you need to, you can crush the immediate release, but you cannot crush the sustained release. So here, just some questions to start any discussion. So we have, the first question is, how would you select an appropriate pain medication and develop an appropriate pain management plan? Okay, so just have a think about that. So how do you know which would be the right medication to start with? And what is the usual starting dose of morphine, and how can we titrate it? And think about what are the side effects of morphine, and how can they be prevented? How can we manage the side effects of morphine? So please do raise your hand or put a question in the chat if any of those questions you need some support with, or please do write your questions in the chat and we can have a look at those, or any other questions you may have following the case discussion. Thank you.
Thanks so much, Dr. Kathryn. Excuse me. We actually have some time now. There's about 20 minutes. And we would love if there's someone from the group that would like to unmute. I think we'll be able to continue to answer questions through the chat. And of course, I can also facilitate those questions that come through. But does anyone have any comments, especially related to those last? Maybe Kathryn, you could copy and paste them into the chat so we can see. Okay, just on a side note, I have put in the link for the attendance, so we would love if you could find that now. And just wait as people are trying to ask them questions. So just reflecting on how do we decide what medication is appropriate, and how do we make a plan for our patients? What are some of the side effects we learned about today, and the starting doses? How do you adjust someone once they've had their dose for a few days or a few weeks, but they're in need of more medication? Kathryn, there is one question I can direct to you. When and how do we use fentanyl patches in pain management, as it was not mentioned among the pain medications? I'm not exactly sure where Chantel is from. But of course, in the context of the focus of this course, maybe Dr. Kathryn, you can also answer that related to fentanyl patches in humanitarian settings.
Yeah, thanks, Erin. So thanks for your question, Chantal. Actually, most people don't have access to fentanyl patches in the sort of humanitarian setting. But if you're lucky enough to have access to them, just be cautious on how you and the team use them. Usually fentanyl patches are something that we switch to once we've got pain under control using immediate release opioids, because fentanyl comes in injection form and it comes in patch. Okay, so we can't titrate them orally, and the lowest patch size that often you can get lower, but often the lowest patch size is equivalent to about 60 to 90 milligrams of oral morphine in a day. Okay, you have to be careful. While everyone thinks, many people think it's just a plaster, we can just stick it on, you can actually cause opioid overdose if you're not familiar with using fentanyl patches. Chantal, do you have access to fentanyl patches in your setting?
I'm not so familiar with Chantal in terms of being able to.
No, they're not readily available.
Yeah.
And then
Yeah.
the cost.
Yeah, that's right, Dr. Esther. They're expensive. They're usually not available. One time when they're very helpful, in case you're lucky enough to have access, is for patients with renal failure and for patients with when they're not able to take medication by mouth who want to be at home. But often they're not available. But just be aware of not titrating acute or uncontrolled pain with a fentanyl patch. You just need to know a little bit about what you're doing if you're using them.
We'll go to Esther. I see your hand is up, Esther Beatty.
Yeah, this is a question for the group because in my experience, opioids were only accessible in the capital city. So, and doctors were only allowed to prescribe maybe like a week or 2 weeks worth. So people who lived, for example, 4 hours away from the capital city had a real difficult time accessing opioids. So I'm just wondering about the experience of other people who are working in East Africa, and if it's possible for, like, how many weeks supply are doctors able to prescribe? Because I know that's one reason why some doctors were telling me they wouldn't even want to prescribe someone on a strong opioid because of that accessibility. And once someone starts having good pain management, and then they go back to their village and they can't access that anymore.
I do know Dr. Esther can clarify. I do know that there is some flexibility in terms of patients receiving the medication compared to a caregiver. And I do know in Kenya, we do manufacture the morphine. I'm not sure if they do that in Senegal as well. But.
So when we are starting a patient on opioids, the maximum prescription we give is for 2 weeks. But then for the patients on regular opioids, we are only allowed maximum of 1 month.
Ali, what is the situation in Hagadera? How long can you prescribe these medications for? 1 week, 2 weeks?
Yeah, and Erin, we normally prescribe 2 weeks, then you observe at a low dose, 10 milligram. In the cases, we normally give 4 hourly of morphine.
Great, and I see one of our other faculty members from IRC in Kenya has joined. Annalise, are you there? Or she was on the call. Might have dropped off. In the second batch of our teaching, we've been really fortunate to be able to bring some new faculty members on the call. The one is a palliative care nurse, senior palliative care nurse working for IRC in the refugee camp in Kenya, and then Ali Hamis, who's our clinical officer in Hagadera. He works in a private facility there, but providing a lot of care to the community and used to work for IRC. So it's always good to get your input. Dr. Kathryn, there was a really good response. I don't know if we would want that healthcare provider providing care for us, but I think it's always nice to highlight when people have very thorough responses in regards to what would you do? What's your plan? And that was Bushra Ali, said to rate the pain, using the tools and develop a plan. 10 milligram starting dose, side effects can become, so be aware of diet, and prescribing stool softeners and enemas. So for that one, I'd say laxatives, if you can, along with the stool softener, and then for itchiness, what to do for that. So it's a great, thorough plan. So starting dose here, someone who hasn't renamed themselves, 1 milligram per kg, per kg. Some of the common side effects. Yeah, I think we've got some good responses there. Kathryn, or Dr. Kathryn, do you have any other final thoughts on the case or just people's response to that?
Yeah, no, thanks, Erin. I'm seeing lots of really good answers coming in, so that's great. So maybe some of you have experience before, or maybe you've been listening really carefully to the lecture. So really good to see that so many of you have grasped the doses and how to prescribe morphine. So that's really good. Yeah, I mean, one other thing, if you don't have morphine or much morphine, because sometimes what you find is you have some morphine, but you might run out of supply if you have a couple of patients on long-term morphine. So you can also add in some adjuvants if needed. So you can continue with like ibuprofen if it's helpful for some patients, and you can continue with, you know, a lot of cancer pain is mixed pain. We didn't talk much about this today, mostly because of the time. We can't cover everything, but a lot of cancer pain is mixed pain. So you may have a neuropathic component as well. And so for some patients, medication like amitriptyline or gabapentin can be opioid sparing. So you may be able to add in something like amitriptyline, and it may just help you to conserve a little bit your opioids, because it is a real issue. You know, in an ideal world, we have this endless supply of morphine and we put people on what we like, but we know that's often not the case. And you may have, you know, a limited quantity per month. And if you use all of it, then you don't have it for the next patients that come in. So sometimes we have to be a little bit strategic and think about how we can be opioid sparing for some of the patients as well. While not leaving them, of course, in pain, but we can use some of the adjuvants, like the neuropathic agents, some ibuprofen alongside the opioids to try to gain pain control. Yep, so just more good answers coming in. Oral morphine syrup, someone's mentioned here, yeah, and the morphine syrup is immediate release morphine, so it's just like the immediate release tablets in terms of how often you prescribe it. So it'd be every 4 hours, and it can be easier for patients who struggle with tablets, especially those in last days of life. Some people find the syrup a bit easier, again, if you're lucky enough to have it, or you can crush the tablets into a small amount of liquid. Yeah, and side effects are coming in. So yeah, well done, everybody. Some really good answers.
There was just one comment here regarding oral morphine 15 milligrams per day or 10 milligrams per day for people that are elderly or maybe cachectic, I'm thinking. I'm not sure if we talked about that at all, but of course, maybe that's also related to the per kg. But oftentimes we don't always weigh people. I mean, we're very good at weighing children, but.
Did you want me to comment on that, Erin?
Yeah, is there anything else to add to that? Just start low.
Yeah, sure. So I think 0.5 milligram per kilogram or thereabouts, or half starting dose of the 5 milligrams would be a safer starting dose for, I think Dr. Esther mentioned over 65 patients, which I absolutely agree with you, Dr. Esther, to start them on a half usual dose of morphine, and you can always increase if they need more. Similarly with patients with mild moderate renal impairment or mild moderate liver impairment, and those with severe renal impairment, severe liver impairment, you have to be very careful because they're going to stick around, particularly with renal impairment. And you may just want to use those medications PRN to be safe. But you can find a lot of information about opioid prescribing we can share some resources, I think, on the site, Erin, right, to give some additional information about prescribing in special circumstances.
Yeah, for sure. We can make sure we have some basic or simple to access for children or people that are low weight, not your kind of standard or elderly people. Okay, so why don't we wrap up here? We're done a little bit early. I just want to go over a few housekeeping things. People are doing really well at the attendance form. It's great. I have shared the link in the form right now. So please, I'm going to give you a few minutes to fill it out. I'm getting about 25 emails a week asking for the attendance sheet to be sent, and not the most effective use of my time. I will continue to share the link. I believe if people are emailing me, we're working on a honor system or so I will definitely send you the link if you somehow missed it, but please keep track of that. It's really important. It really helps our team at the end of the course to make sure that you can get a certificate. We've just started it this time, and it seems to be working well. Each time I'm getting about 40 to 50 people on the attendance sheet, so I think it's really going to help us. And then if you miss a visit, not a visit, sorry, if you miss a class, and there's issues with your internet, or you don't really feel like you fully were able to grasp all the content, again, this is another honor system thing. We would really appreciate if you could follow up with the recording over the week. There isn't a deadline for this. The deadline will be the end of the course. So if you're having a busy week or there's lots going on at work or in your personal life, you can find another time to catch up. We just are going to require that all participants listen to the recording. So they're 1.5 hours. And if you didn't attend the live session is when you can ask live questions, you can put questions into the chat, you can engage. So there's obviously a benefit for coming to live sessions, but if you can't or your internet is not great, it's more, you're just listening. You can't really comment. Of course, you can stop and pause and make notes, but you can't really interact with us as faculty. So that's why we're requiring all people that listen to that recording finish a quiz. And the quiz is on the regular emails that I have sent out. It is a link, and it will say specifically add your details for your name, and then it will say what week did you miss. So each time you do that, if say you missed 2 or 3 sessions, you need to do a different quiz every time, because you only get an option to click a week one time, and then the form is submitted. So hopefully that's clear, and I do hope you are able to join us live. We're getting really great interaction in this group, and we're really proud of you guys for continuing to come out. I know it's not easy. And throughout the week, if you are finding as we are going through this course that you are in need of more support, or maybe you would like to connect with one of our faculty members one-on-one through email or a chat, please don't hesitate to do that. That is a big part of this course. We are 15 members on the faculty team. We have Kenyans, we have other East Africans, we have people working in humanitarian settings, and we also have our international experts that are or have worked in humanitarian settings before. So we are here to help you. We can find the connection. Dr. Kathryn and I represent PallCHASE. If you are feeling like you would like to advocate for better access to morphine, especially after the call today, please email us. We may not be able to do it ourselves, but I think with our network, we can find someone who can find someone to help you. It's not easy to advocate for these kind of things, but if we don't start now, it's not going to just happen on its own, I believe. So we need you as primary healthcare workers, frontline workers, to be part of the team of advocating. Of course, we can also advocate, but we aren't seeing the issues day in and day out that you see. So please don't hesitate. You know the email address. Of course, we're also on the WhatsApp. I will share the attendance link again. Please, 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 everyone, fill it out right now. Thank you, of course, for everyone that has been filling it out. I do appreciate it. I guess we have one final question here, Dr. Kathryn or Dr. Esther. There's a question about naloxone. Is there a specific dose? I think, Dr. Esther, you had said that. And Dr. Amable, it seems like you are a palliative care provider already. You want to unmute and introduce yourself? I'm not sure where you're calling in from today. Maybe you haven't lived in Africa long enough.
Thank you. Thank you. I'm just a physician. I've been having some training on palliative care and pain management.
Nice.
So I always want to get more experience with you and all healthcare providers. That's why I try to look for trainings for other courses that may help me to enhance my knowledge. Otherwise, I'm very good and happy to learn from you all. Thank you.
Where are you calling in from?
I'm from Rwanda, Gihundwe Hospital.
Okay.
It's in the West, but
Nice.
actually I'm a national trainer on pain management and palliative care. So there is what we call a pain-free hospital initiative that started here in Rwanda. So we worked together with the American Cancer Society to enhance the knowledge on pain management and pain and palliative care in different hospitals in Rwanda, and among the one who facilitates. That's why we always need to work with you. Thank you. So
I think I'm gonna email you and recruit you for our next group.
Thank you very much. I've already wrote to you an email.
Okay.
I think we can keep chatting and discuss more.
Yeah, perfect. Okay. Sounds good. I know there's a few, Dr. Anna, I know you're not always on the call. Do you have any final words of wisdom for our group here?
No, I just really am impressed by all the interaction and participation and questions and answers. It's really great to see. So thank you for wanting to learn and your curiosity. Really appreciate it.
Esther, do you have any? I'm doing the very Kenyan thing.
Final comments, yes. I think we should share the handbook from APCA with the participants on beating pain, so that they can also go through some of the things that we might not have covered during this presentation.
Yeah, it's
so
a short.
They can go through it. Okay. Yeah. Otherwise, it was a good session. Thank you.
Yeah. Esther Beatty, any final thoughts? Okay, and Kathryn.
I think I did my final words, Erin.
Seriously, I'm being very Kenyan right now. Okay, the call is over. Go do what you were planning to do. We'll see you guys around next week is week 5, and I will send the topic shortly. Bye, everyone.
Thank you. Bye.
Bye.